Taiwan. It's a great honor and pleasure for me and for my colleagues to welcome Professor J.P. Hong to come to Taiwan again. Yeah. How many times do you come to Taiwan?
At least twice a year.
Twice a year. Anyway, good to see you. Very good to see you. So, special thanks to our sponsor to invite JP to come over to our annual conference, and thanks JP to spare his time to come here a day ahead to give us this lecture here. So I think you just arrived and rushed from the airport.
Yes.
Here. Wow. Thank you very much. Yeah. So today JP is going to share with us about some ideas and innovations about loading reconstruction. We know it's a very difficult part of the plastic and reconstructive surgery, and JP has done a lot of work, and he has traveled a lot to talk about his ideas and innovations. So this time we welcome you here to share with us your ideas.
Thank you. Thank you. Thank you so much, man. Thank you. I thought it was innovations in diabetic foot reconstruction, no? It's innovations in lower extremity or diabetic foot? Diabetic foot, right?
Diabetic foot.
Okay, okay. All right, so thank you, everybody. It's really good to be back in Taiwan, especially to Taiwan National, because I don't know if you know, but Jimmy was my fellow for 1 year, and we really had a wonderful time with him. I finally made him a person who can drink more than 2 shots of soju. So congratulations. All right, so I'm going to be talking about diabetic foot, and he asked me to talk 30 minutes so everybody could go to lunch and not starve in the afternoon. The good thing about the talking before lunch is that nobody's going to fall asleep. But anyway, I'll be talking about diabetic foot, and one of the, I think we don't see many plastic surgeons do diabetic foot, and I always ask myself, why don't a lot of plastic surgeons do diabetic foot? And because diabetic foot is just difficult. If you look at the spectrum, you know, we have to know about endocrinology, and then we have to know about wound healing, we have to know about the science of wound healing, and of course as surgeons we have a lot of surgical options. And I'm not going into all these fields because there's only 30 minutes of this. Unless you want to do 3 hours, maybe I could talk everything. But today I'd like to focus, as a plastic surgeon, what are the surgical options that we have, and what innovations and what are the latest technologies or ideas that is involved in reconstructing diabetic foot. And I think there's many things as surgeons that we face, especially in terms of microsurgery. We utilize a lot of that, which is a lot of the innovations are basically pivoting around. But I think one of the biggest things that really came to our service that really made a difference is when we cannot do active reconstruction. What are the options that we have when the patient is too sick for a 3-4 hour surgery? Or when you're in a conflict where you say, this is too much for a flap, but we need some kind of coverage. And I think this is where the dermal metrics really comes in. And I hope that a lot of you will have the opportunity to use this. So what it does is that it really allows to have a faster rate of granulation. And we use this in cases where the patient's too sick, or we lost the flap, or we know that the flap is not going to be successful, especially in ischemic conditions. And I think this really made a huge difference in my practice. And I'll be talking about this more tonight. And a lot of the innovations that we've structured around is based on reconstructive microsurgery. And of course, for any reconstruction, especially in the lower limb, including diabetic foot, the goal is to have the patient use their own leg. And this is the basic algorithm that we have. And the most important question that you have to ask when facing diabetic foot is, did the patient walk before? And if the patient did walk before, and I think it's really worthwhile to reconstruct, especially in diabetes, the patients are usually in their 60s, in their 70s. And if you amputate and then expect them to use a prosthesis, they're never going to walk again. So older, you have to do more reconstruction to save their leg as much as possible. If it's a young diabetic, they have a very good chance to have a functional outcome using prosthesis. So it's a little bit different kind of thinking. So despite the patient's old, we really have to do our best to salvage their limb. And everything starts by really understanding blood sugar level, because we know that when it's not well controlled, and this is why you need a multidisciplinary team, there's just a very high rate of complications. So it's very important to treat a blood sugar level, and you need to work very closely with our endocrinologist. Now, the main indications in our practice for microsurgery is when the patient at least have one vessel, when the healing process has stopped for at least several weeks, when there's, of course, infection involved, especially in the bone, and it's just a defect that is too large, that has exposure of many vital structures. And if you're thinking about doing reconstructive microsurgery, the foremost key is to understand the vascular status. Without good vessel, reconstruction is impossible. So when the patient walks in, you have to look at the vascular structure first, make a decision whether or not we could use the current vessels or we need to improve the vascular structure. So here in this patient, just looking at a CT angio, we know that this patient has a posterior tibial, but no anterior tibial. So it's also very important to look at the local structures of the vessel, but at the same time, it's very important to review the whole leg. Because a lot of times in ischemic diabetic foot, you'll see a lot of obstructions and a lot of collaterals instead of the femoral artery. In this case, the descending branch is the main collateral supplying the blood through the distal part of the leg. And in this case, if you use an ALT, you are potentially sacrificing the whole leg. And this is why it's very important to understand the whole vascularity of the lower extremity. And if you do see cases where the flow or the vascular structure is not really adequate, then of course you have to enhance the flow by doing angioplasty or by doing bypass. And the goal here is to maximize the flow going into the distal leg, because better the flow, the better chance of reconstruction. So it's very important to do that. And once we improve the flow, then of course we could consider doing about free flaps, and I think we all know what a free flap is, using a vascularized tissue to do the anastomosis to the recipient. A very important concept also is regarding, especially in ischemic diabetic foot, is understanding the angiosome. Because when there's an ischemia territory of a single angiosome, you will see a pattern of ischemia that follows one of the 6 angiosomes in our foot. And it's very important to debride the entire angiosome. Why? If you don't, the surrounding skin is also going to have poor vascular supply. And if the surrounding skin has a poor vascular supply, then you're just going to be left with an island of flap, will ultimately fail, because the ingrowth of the vessel has to come from the surrounding tissue. So when you debride, you must have a healthy surrounding tissue. And this is why, especially in ischemia, you must debride according to the angiosome concept. So this is a typical case where we see from a diabetes, and it's very important that you always have to clean the wound. So for us, one of the clinical signs of having a good wound is usually getting this kind of fresh granulation, tight granulation, and this is easily achieved by using a negative pressure wound therapy. And then once the wound is clean, we're able to do a free flap and salvage this leg. There's a lot of dispute on what is an ideal flap. Is it muscle or is it skin? In our case, we like to use the skin because we know it's more durable and we could really have a thin flap elevation. But muscle flaps does the same job. So whatever you're comfortable using, I think it's good for you. But in looking back in the anastomosis of microsurgery, you need at least one good vessel to hook up the flap. This is important. And a lot of the times you'll see that this vessel is also calcified in ischemic conditions. So it's very important to find a segment that is spared from calcification to hook up the flap. And if it's a stump, of course, you can do it end to end. We always have to do side of the recipient vessel to the end of the flap because you need to preserve the flow as much as possible. If you do end to end, you're sacrificing the distal flow, and there's a potential you'll decrease the flow distal to the anastomosis. So here's a typical case of first-ray ischemia. Maximize the flow using angioplasty, as you can see here. Then we debrided the whole first ray according to the angiosome concept, elevated a thin ALT did a wraparound, and this is the result after 10 years, being well used, well preserved, even with the first toe intact. We all know how important the first toe is in the push-off of the gait, and this is very important. In these kind of cases where there's severe calcification, what we like to do is even before debridement, we like to look at the recipient site first, and you can see that clearly there's multiple calcification. We want to make a small puncture, make sure it works. And once we see that small puncture, we go ahead, debride, elevate the flap, do the anastomosis, and we're able to salvage. So the premises of microsurgery here is that at least one major vessel is functioning. And you have to use the segment that is spared from calcification or a branch from this major vessel. And through our experience, we now have the ability to have a flap survival rate around 92%, limb salvage rate around 85%, and what is very interesting is a 5-year survival of 86.8%. Why is this important? I don't know if you know, but once a diabetic foot patient undergoes major amputation, there is a concept of 5-year survival. You only hear 5-year survival in cancer. But once a major amputation occurs in diabetic patients, 5-year survival is 50%. It's the same as colon cancer, or almost a little bit better than lung cancer. But we never talk about 5-year survival. And what is interesting is at the same time, the patient that underwent major amputation, 5-year survival of only 41%. And this is also similar in other parts of the world, such as Georgetown result, which give almost the same result. So by reconstructing and having the patient walk on their foot, of course their lifestyle improves, and overall their 5-year survival also increases as well. So now you know, as plastic surgeon or as microsurgeons, we not only have the ability to improve the quality of life, but we also have the ability to improve the quantity of life. At the same time, we identified multiple risk factors. History of multiple angioplasty, 17 times higher. Peripheral artery disease, 10 times higher. Immune suppression, 22 times higher of failure. So for those young surgeons who are trying to do diabetic foot, maybe these are the patients that you want to avoid in the beginning, and ultimately try to go for easier cases and ultimately approach these cases with a little bit more difficulty. Now, what we also found out was that in looking at the region of the reconstruction, heel pad reconstruction was the most difficult in terms of outcome in diabetic foot. Why? Because the heel is always surrounded by poor skin, because it's a watershed region. And this is why surrounding skin needs to be very healthy. And in our case, before we realized that, we had a 73% of a very low success rate compared to the 92% overall. If there's only one collateral feeding the heel, it's an 80 times higher risk. Only one dominant artery, it's a 9 times higher risk. So even if one peroneal artery or one posterior artery is intact, you still have 9 times higher rate of failure. So you have to make sure that you debride wide to make sure that the surrounding tissue is intact. But what about these leg? Extreme ischemic diabetic foot. So here you see that there's no major vessels going into the foot. So what do? Do we just amputate, give up these patients? And this is where the concept of supermicrosurgery comes in. We all know supermicrosurgery is a concept of doing anastomosis of less than 0.8. So what does this have to do with diabetic foot reconstruction? And we start to ask ourselves, if perforator can supply the vascularity of a large skin tissue, why not use the same perforator as the recipient source? So hence, we introduced the idea of perforator to perforator supermicrosurgery. And again, going back to the angiosome concept of the foot, 6 different angiosomes. And if you look at the ischemia pattern, even though this patient does not have any major vessels, you see that somehow part of it is ischemic and other part is pink. So even though the patient doesn't have any major arteries going to the foot, anterior tibial and posterior tibial, how can they have this kind of pinkish regions? So this is the question we asked. And this happens because as the occlusion of the major vessels approach more than 75%, we suddenly see increased numbers of collateral vessels and increased diameter of the collateral vessels. So as the obstruction proceeds over 75%, we suddenly see more collateral, and we see collaterals with larger diameter. So we said, aha, maybe we can use that as a recipient source. So we started to use the ultrasound to identify these collaterals and also measure the vascular flow. And if the vascular flow is over 15 to 20 centimeters per sec, we see that there is a relationship favoring success of the microsurgery. And that's how we start to do reconstruction. So here's a typical case. First ray, after angioplasty, we improve, find the small perforator, probably stemming from the medial plantar, and this is the reconstruction. Similar case, ischemic case, finding a perforator, hooking up the ALT, and then we're able to salvage the limb, the foot at the mid-metatarsal level. Even in the first toe with chronic osteomyelitis, instead of amputating, now we're using digital arteries to hook it up and salvage the first toe. So now, despite the fact that we don't have any major vessels, we're still able to find good recipient source for reconstruction. A lot of people ask me, what about hyperbaric oxygen? For us, hyperbaric oxygen is to demarcate between poor supply and good supply. Because a lot of the times, if you reconstruct the diabetic foot when the surrounding tissue is poor, then the amputation level keeps on going up, 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 up. And this is why hyperbaric allows us to completely understand the demarcation point. And after that, we're able to debride, find a perforator, use an ALT, and have this patient salvage the foot at the mid-metatarsal level. So again, the idea of the supermicrosurgery is we find collateral vessels, we find perforators, do an end-to-end anastomosis, and then of course we do we salvage the limb. And the flap survival in these series was a little bit lower than the regular microsurgery, which was 92%. But nevertheless, we're able to have in this extreme ischemic diabetic foot, 90% and over survival with an overall limb salvage rate of a 93.7%. And what was interesting is that patients that underwent multiple angioplasties, patients that had peripheral artery disease did not have that much risk of a failure. So this was very interesting to see. And all this is made possible because now we have extremely good instruments. So now for those young people say, oh, you know what, I cannot do supermicrosurgery, it's an excuse. In the days that when we started, we didn't have these kind of 11.0, 12.0 ultrafine sets, very good microscopes. But now we have this, and it makes the supermicrosurgery much easier, utilizing crown Jun instruments, ultrafine microscopes, and of course the ultrasound. And now, even now, if you say, still very difficult to do, now the introduction of the robot, I know there was a robot also in the microsurgery meeting from Japan. This robot allows anybody to do small dimension microsurgery, and this is a very exciting part of the innovation. So you can see there's multiple advantages of using the robot. You don't shake, the scale factor is incredible, and you're able to do 0.3, 0.4 with just 5 to 6 tries. And in addition to that, now it's more exciting because now we have digital microscope being applied into our field. And what does this mean? It means that we're now able to extract 3-dimensional data for the first time. And once we have enough 3-dimensional data, that means that the robot can automatically do microanastomosis. So it's an incredible time, exciting time to see these innovations in our field. Nevertheless, for now, we have to do hand microsurgery and really allow the best possible care, including good post-operative care, as much as possible. Now, the problem with ischemic diabetic foot is that the patient undergoes angioplasty and they open the vessel. But the problem is, once you open the vessel, it's not permanent. It will reocclude. And what's interesting is that the reocclusion rate is high as 60% within 2 months. And this is why once we open up, you immediately have to do the reconstruction to maximize that patent period, allows the flap to take. And this is why immediately after angioplasty, we do it within 1 or 2 days, or we do it in a hybrid room in a single opening and then a simultaneous reconstruction. So here, I'm sorry about the video, it's not working. So what we did was that this patient had a mottling like this in day 5. It was perfect, and then it turned like this. Look at this. We're not sure if it's congestion or ischemia. So what do? We call our angioplasty guys, and they actually looked, and the proximal portion, proximal to the anastomosis, had a new occlusion. So what they did was angioplasty, and the flap survived without a problem, like this. I'm sorry about the video of the angioplasties, but anyway, when you're doing diabetic foot reconstruction, it's very important to have an angioplasty team ready for you when you have especially these kind of post-operative complications. So by doing a reconstruction in diabetic foot, now as plastic surgeons, it's a little bit more difficult. We have to understand the concept of orthopedics. We have to also understand the concept of vascular. So I really think that the diabetic foot reconstruction is orthoplastic vascular approach. And I think it's very natural that you understand this kind of concept. And of course, we talked about the algorithm. We talked about how we're able to help these patients. So back in 2005, when we first started the multidisciplinary approach for diabetic foot in our center in Asan, in Seoul, the major amputation rate was 22% in 2005. By using this kind of microsurgery approach, now we have less than 2.4%. Every diabetic foot patient that walks in, we're able to save 97.6% of the time. So now we're having a very low amputation rate. But are we near perfection? So I mean, this is one of the questions that we always ask. And when we see this kind of wound, we start thinking about closure. We start thinking about flaps. But what is the real problem here? The real problem is that the bone is pressuring the skin, and that the bone is infected by prolonged exposure. So you have to start thinking, how can the patient benefit by avoiding amputation? So what we do nowadays is we looked at the segment of the infected bone, we looked at the skin, and now we know clearly, if we remove this pressure point of the metatarsophalangeal joint, maybe the patient has a good chance. So what do? We debride everything, we put antibiotic beads only, and then we close it primarily. The patient has a Shudo joint, infection is controlled, and we're able to close the wound, and the patient is walking with this foot. So understanding this kind of orthopedic concept to address the problem of pressure and infection, we're able to have this kind of result. What about this case here? We did a beautiful reconstruction using an ALT, but the patient comes back with reulceration. One of the critique that we face is when you do flaps in diabetic foot, everybody's going to be reulcerated. That's one of the critics. It doesn't matter if you use muscle or skin. They always ask, what is the reulceration rate? And I found out that this is one of the most stupid questions. Why? Because reulceration occurs because the patient is using too much of the forefoot. So what is the main problem here? The patient has Achilles tightening. So as plastic surgeons, we didn't know this kind of orthopedic concept. So what do? Achilles lengthening, and the flap is completely safe. So the recurrence is not related to what type of tissue we use. It is related to the bone kinetics. And this is why understanding the orthoplastic concept is so important. What about this case here? When we do this kind of salvage, the orthopedic surgeon calls me and says, "What is wrong with you? You should have done a circular type of midfoot amputation." I said, "Why?" Because the patient is able to walk better and have less complication. And that was not true. Because we actually did a study that looked at having 2 or even 3 or even just one first toe, And during the time the patient has the toes, they actually have a better functional gait. So now we're able to even teach the orthopedic guys. But it also, agree with them, this is after 15 years by the way, you could see that the toes are migrating toward the center because they don't have a support. And ultimately, this will have a joint exposure. But when you ask the patients, do you want to walk well for 15 years and have a complication? Or do you want to do a metatarsal amputation and walk with poor quality? They all choose this. So now we have more data of helping even the orthopedic surgeons think about their approach and how we could apply this as an orthoplastic concept. We also do a lot of nerve decompression. I'm not going into details about this because I know you guys are doing as well. You basically release in the cases where they have Tinel sign, and then the patient is able to improve their peripheral senses. But what we are doing quite a lot is this kind of superficial vein arterialization. So it's like a venous flap. So we're actually hooking up the perforator into the side of the vein, ligating the proximal vein, and we're arterializing the distal foot. And you can see immediately the change in the patient's temperature. So this is like doing a venous flap. So in cases where the patient does not have an ulcer, but has a severe pain due to ischemia, this type of arterialization of the superficial vein helps them to regain a better quality of life by improving their pain. Now, we were taught for a long time amputation is the devil, and we are the angel because we are able to reconstruct. But we're also taught by Dr. Attinger that amputation is also reconstruction. By using a vascular fibula strut, we're able to stabilize the stump and minimize the torque, which causes pain. So now when we're doing amputation, we're doing that vascularized fibula strut to stabilize the stump as well. At the same time, I know you guys are doing it, TMRs and RPNIs, which manipulate the peripheral nerve, the distal stump, and manipulate it so that the patient doesn't have neuroma pain or phantom pain as well. But what are we really creating here? We are creating a new neuromuscular junction. So we're creating a new terminal with a signal. So what do we do with that? Now we're hooking up robotic prosthesis directly into the new neuromuscular junction that allows to signal sign into the prosthesis. So now the patient can control their ankle and also their knee in an AK amputation. So we just recently finished a clinical trial with 36 patients, and they actually have a much better quality of gait. They use much less energy in long-term walking. So can you imagine in diabetic foot reconstruction, now we're even talking about bionics. So it's a very exciting time to be a microsurgeon. And as you can see, the cadence, the energy expenditure is all improved in using a robotic bionic prosthesis. So we're in a very, very interesting time right now. It's good to be a microsurgeon, especially helping patients with diabetic foot. It all used to be about minimizing amputation, but now it's about extending their life. Not only their life, but maximizing the quality through robotics and through supermicrosurgery. And all this innovation built around microsurgery, built around ischemic diabetic foot, is a very exciting time. So with that, 30 minutes exactly. Thank you so much.
Thank you. Thank you, JP, for giving us such a comprehensive talk. You mentioned about the innovation in many, many fields of the diabetic foot reconstruction as well as the new therapies. So, especially supermicrosurgery, what do you foresee its application in diabetic foot reconstruction? Can you tell us more about it?
Right. So, you know, in the past, when we didn't have the ability or when we didn't understand the physiology and the anatomy of the collateral vessels, we always amputated or let the patient heal by secondary intention, which was very painful. But now utilizing these small vessels, now we're able to arterialize the foot in patients with severe ischemia. We're able to use that recipient source, the collateral, to hook up a flap. So I think this really allows us to expand the reconstruction into the realm of ischemic diabetic foot, which was once always indicated for amputation. So I think this is opening up a complete new possibilities to really push the envelope in helping patients, especially for ischemic diabetic foot. So I think this allows us to just basically address most of the patients that may need a reconstructive limb salvage.
I think for the vascular surgeons or the internists, they have a device that can use the cast to bypass the arterial flow into the venous system at a higher level.
Yeah,
What do you
great
think about
question.
that technique?
Great question. That is a very good question. The reason why we do arterialization distal to the ankle is that the number of venous valves are very, very low distal to the ankle. If you want to do arterialization proximally, you have to do valvectomies. And the more valvectomies you do, the higher chances of, I think in my mind, complications including thrombosis. So instead of sacrificing a major vein, we go distal to the point where the ischemia pain is the maximal, and then utilize the fact that there's no valves, so we don't need to do valvectomy, and then arterialize the venous flow. So that's the idea behind this.
Thank you. Any questions from the floor?
Yeah, thank you very much for this form. Yeah, when you talk about the indication of diabetic foot reconstruction, and I see some of the case, actually that, to me, they are contraindication because it's quite difficult, and we usually do the amputation first. I think the main reason you turn the contraindication into the indication is that you can find a suitable artery for recipient artery for vascular hookup. And so my question is, how, and you say you have to find a segment, a spare of calcification. So can you talk about it? You use ultrasound to detect before open the skin. And how do you find a suitable?
Right. Another great question. So if we're going to use a major vessel with calcification, then we look at multiple things. First of all, X-ray. It's the easiest. If you look at X-ray, if the vessel is calcified, you could actually see the anterior tibial or the posterior tibial being calcified. And you could see the segment where it's less calcified. So that's number one. X-ray is the easiest. And if we define a segment that is less calcified, then we bring in the ultrasound. And we actually look at the segment that is less calcified, and we also look at the wall. You could actually look at the wall, how calcified it is. And number two, you could actually measure the flow. Sometimes you see a vessel, and if there's a proximal obstruction, there could be no flow. So you have to look not only at where the calcification is, but you also have to determine actually where there is a flow or not. So using both X-ray and the ultrasound allows us to pinpoint potential sites for anastomosis when you're using the big vessel. Now the good news is that we were taught in med school that diabetes have microangiopathy, but this is a complete. It's not a wrong concept, but it's a wrong wording. Because if you look at the branches coming out from the major vessels, it's very rarely calcified, especially at the level of collaterals. It's never calcified. Only the major arteries are calcified. So if you see a nice branch from a major vessel and just measure the flow, sometimes that is also very reliable to use. Thank you.
If there's no more questions, we have a group photo first. Then we
Excellent.
finish. And if there are any more questions, we can discuss it later, right?
Excellent. Thank you very much. 谢谢。
放后面我